All right, hopefully we're going again. We talked about this last time, and I think it's just really important for us to recognize the environment that we practice. So the Department of Homeland Security defines austere EMS, and I think you'll find that a lot of these relate to our work as ski patrollers. Ongoing physical environmental threats, limited supplies, limited resources, limited communications, and duration of care that gets extended. And so we have to give ourselves a little pat on the back that we are practicing in an austere environment, and that changes a lot of the work that we do as ski patrollers. So tonight, just as matter of reference, if you want to circle back to your OEC text and look at these kind of chapters, we're going to be talking a bit about Chapter 9, Airway Management, Chapter 13, Respiratory Emergencies, 14 for allergies and anaphylactic, and then touching a little bit on Chapter 28, altitude-related emergencies. So our first lecture, we really went over that foundational primary patient assessment. And so OEC has two schools of thought. Starting with circulation, if you have someone that has significant hemorrhage and bleeding, otherwise going through that normal algorithm of the ABCD. And we've talked about how, some other perspectives, these all kind of align with OEC, but they give us some different kind of perspectives to think about this primary patient assessment. In the kind of modern EMS paramedic school of thought, they talk about XABCDE. And what I think is really important there, again, is thinking about exposure, thinking about something like the environment and hypothermia. And then on the military side, with our tactical combat care, obviously addressing massive hemorrhage. That's what they're going to, potentially see in war zones. But again, ending with that really aggressive awareness and management of hypothermia. And so hypothermia is certainly very significant for our trauma patients. When we talk about those effects of bleeding easier and having more significant blood loss as a result. But with all of our kind of medical assessments, we also want to be thinking about hypothermia in the back of our minds. And then ultimately what we're trying to do with that primary patient assessment is figure out relatively quickly, is this someone that is big sick or little sick? Is it someone that's big hurt or little hurt? And so we want to keep that kind of in the back of our mind as we're thinking about some of these medical conditions tonight. So after we've done that primary assessment, history taking, this is going to be really important for the medical conditions, that we get a good history, and we're going to talk through a bit of what that history looks like and what important questions we want to be asking. But I like to, when I'm doing a medication history, from both medications and past medical history, I like to lay out for patients a kind of list. Have you ever been told you have high blood pressure, high cholesterol, heart problems, diabetes? Because you will find that patients have this natural inclination that if they're taking their blood pressure medicine, they don't have high blood pressure anymore. So we want to prompt them to really be thinking about the problems that they don't think they have. So let's kind of dive in and start talking about airway management here. So starting off, we are performing a primary assessment on an unresponsive patient that we found lying on the ground. We don't see any signs of trauma or hemorrhage. We've manually adjusted their airway. The patient is unresponsive. And so what's our next action that we want to take, thinking about that primary assessment? I'll give you a clue because we're on the airway section right now. So do we want to look, listen, and feel for air movement? Do we want to insert some type of airway adjunct? Do we want to apply a non-rebreather mask with high flow? Or do we want to count the patient's respiratory rate to determine if it's adequate? So let's throw that in the chat. What do you guys think? So for this type of a patient that we have someone that is completely unresponsive, we really want to make sure that we finish the whole airway part before we start moving to the breathing part. And I think for a lot of us, we have this kind of natural instinct that if my patient is unresponsive, but things are going okay, I'm going to just move on to the next part of my examination. But just because you've been able to manually open that airway, what's going to happen when you take your hands off and you're no longer doing that head tilt chin lift, or you're no longer doing that jaw thrust? And now you potentially have the opportunity that that patient is going to develop an airway obstruction. So when we have a guest that is completely unresponsive, we really want to make sure that we secure their airway when we're doing that airway assessment before we start moving down the line to the next steps. So when we think about airway anatomy and we're doing that airway assessment, right, I like to, ask my patient, hey, what's going on? What's your name? And if they can speak, we have a sense that their airway is patent. The other thing that I'll do is ask them to spit out any gum or anything else they have in their mouth, because I want to prevent that future airway obstruction. And then some of the red flags that we want to be thinking about when we're really thinking about an airway on a patient is one, and we'll talk more when we talk about some of the pediatric considerations later, but stridor is something that should, really have you be thinking about that they have a airway narrowing. And so stridor is going to be a kind of high-pitched musical whistling sound, and that's due to that narrowing of the airway. And it's typically going to be when they're breathing in that you hear that sound. The second is if you have someone that is not able to swallow their secretions and you're seeing drooling, that is a sign that they have some airway swelling going on. We'll see that a lot in kids with anaphylactic reactions. So that's something that wants to kind of raise some hair on the back of your neck. And then lastly is snoring. I think for some of us, we have that kind of natural inclination of, well, if they're snoring, I can hear that they're breathing, and that's giving me some feedback that they're breathing. But snoring is usually caused by that tongue going to the back of the airway and actually causing some airway obstructions. So we need to address it. One of the things that can become challenging is if we have a patient that's really obese. And this may not necessarily be an individual that's skiing on our hill, but it could certainly be someone that's up for snow play or, visiting the resort, wanting to go up to the mountains. And so one of the challenges with an obese patient when you're doing airway management is that if you have them laying flat on the ground, all of that weight of their upper torso is going to be compressing down on the soft tissue structures in their neck. And so one of the things that's very helpful for kind of airway management in a patient that is morbidly obese is building up some padding behind the back of their shoulders and their head, so that you're kind of getting to where their earlobes and their ear is right at the level of their sternum there. And that really creates a more ideal airway that patient is not going to be having an airway obstruction just from all of the weight of that position laying flat.
Brett, did you see the text in chat that Doug put on there?
Yeah, so Doug, I don't think it's, if we have a patient when we're doing that initial airway assessment that they're unresponsive, we have their airway open, and we kind of get a sense that they're breathing, I think airway adjuncts are really important as we go through that primary assessment. You're probably doing a couple things at once. So yes, if you had a patient that was, while you were kind of doing the work of maneuvering their airway and they're clearly not breathing, you're going to follow that CPR protocol. But, I think it's not necessarily always going to be doing everything for the airway, doing everything for the breathing, doing everything for the circulation. You're going to have a little bit of fluidity that as you are addressing the airway, you are getting
wrong.
Go ahead, Barbara.
No, go ahead. I'm concerned about the fact that you said securing the airway. As OEC technicians, we do not secure the airway. We may insert an adjunct to help try to keep it open, but securing the airway is a term that implies putting in an LMA or endotracheal tube. So you need to be very careful with that.
Fair enough. Then I'll say protect the airway or insert an airway adjunct. So two of the airway adjuncts that we have are the NPA and the OPA. So the NPA, one of the nice features of this is that this can be used in a patient that is semi-conscious because it's not going to induce that gag reflex. We do want to be careful if the patient has facial trauma because that's going to be a contraindication for using an NPA device. We measure it from, as that picture illustrates, the nose to the earlobe there. Ideally, you want to have one that has lubricating jelly on it. You don't want to be inserting it dry. You can use the patient's saliva if you don't have any other options. And these are designed to be for the right nostril. So that bevel side, that cut side that you can see in the photo there, that's facing towards the septum. So you want to insert this in the right nostril. For the OPA, this is going to be in a patient that is fully unconscious that doesn't have a gag reflex. You could use it in a patient that has some sort of nasal trauma where you can't use the NPA. You're measuring it from the corner of the mouth to the angle of the jaw. And then you want to insert it in upside down and rotate it 180 degrees as you're inserting it. If you have a tongue blade that you use in your patrol vest, you can use that tongue blade against the tongue to kind of to hold down the tongue while you insert the OPA. So another question here. We have a patient we're doing a primary assessment on. They're unresponsive. They have significant trauma mechanism of action. What is the most appropriate technique to initially position their airway? So if you want to post in the chat. Great. So exactly. Jaw thrust is the ideal technique here because it has minimal cervical spine movement when we're doing it. If we do that head tilt chin lift, we're extending that neck, and we do not want to do that type of a maneuver in a patient that we suspect could have any type of cervical spine injury. I'm hoping that sound will work. It should. Let me know if you're not hearing sound and I can narrate a little bit. Do you guys hear sound? Cool.
I don't know about everyone else, Brett, but I don't hear any sound with that.
You don't hear sound?
No, I can't
Okay.
hear.
Me either. Nope, not me either.
No sound, Brett.
No sound.
Okay, so I'll go back. So he's tilting the head back by pressing on the forehead. and then holding on the temple, pulling the mandible, and that's lifting the tongue away from the posterior pharynx. And then in the jaw thrust, which they're going to show next, is what we want to use. Putting your palms on the patient's temple and then getting under that angle of the jaw, you're pushing that jaw forward, and that lifts the tongue and the jaw away from the posterior airway. Sorry that the sound didn't work for you all. So we're going to talk a little bit about BVM ventilation now. BVM ventilation is one of those skills that is easy to do on a mannequin and is much harder to do on a person. And so there's some kind of high yield tips that I think can help you all. If you're going to be doing BVM ventilations on a patient, it's very helpful that you use an airway adjunct. So if you already had an OPA or NPA in, you can use both an OPA and an NPA. The goal is that you're getting that effective ventilation on the patient. Whenever possible, I think that two-person ventilation is much easier because you can have one person that's getting that proper mask seal and the other person that's doing the ventilation itself. One of the kind of tricks for when you are doing BVM ventilation is that rather than just kind of pushing the mask down onto the face, you really want to be using through your handhold, lifting the face into the mask. You don't want to necessarily push that lower jaw down and create that posterior tongue to fall. And then if the patient has facial hair, it can be difficult to get a good seal with a BVM. And so you can apply lubricant over their beard, and sometimes that helps you get a little bit better of a seal. One of my kind of techniques that I really like when I'm doing BVM is that if your patient's already on the floor, you can kneel next to the patient and you can press that BVM mask against your thigh. I found that, you know, when you get into a situation, a rescue situation, you have a patient that's not breathing, you get that adrenaline going. It's pretty hard to do some of those fine tactile movements, and it can be a little bit hard for me even to squeeze that BVM mask when I am feeling a little bit shaky. So you want to be aware of ventilating too quickly, because that can create gastric distension. So instead of the air going into the lungs, we're now getting the air going down into the stomach. That can cause vomiting. And the best way to prevent that is by doing a slow and steady squeeze of the bag. And when we're doing rescue breathing, we want to be doing one breath every 6 seconds. And if you have a patient that is not breathing and you have your adrenaline going, 6 seconds seems like a really long time. And so there's a tendency for a lot of rescuers to kind of accidentally hyperventilate their patients. So as part of that kind of team feedback, when we're all on a scene together, it's helpful if you give some feedback, look at your watch, see how that person doing their BVM is doing, and give them some feedback if they're ventilating too quickly. So this is going to show two of the techniques for BVM, and I recognize that you guys can't hear the sound there, so I'm going to give you some feedback. So they're putting in an oral adjunct. They're putting in the OPA into the unresponsive patient. They're doing an NPA there. And so they're putting the top of the mask at the bridge of the nose, and then they're using that C-E hand position. So the C is pressing down on the mask, and the E is pulling up on that mandible. And so you can provide a little bit of that jaw thrust with that E part of your hand. And so if you have 2-person BVM, you can be using both your hands to get a really good seal on that mask, and that makes it a bit easier to get those effective ventilations. And I'll show you a picture of what that looks like. It'll help illustrate it a little bit better. So the two kind of ways that you can do a 2-person technique is you can, so there's that EC technique that they showed in the video, where that E is holding onto the mandible and the C is holding onto the BVM. You can also use your thenar eminence, which is that kind of ridge along your thumb, and that can help you get a good seal. The mannequin has a plastic face, so it's pretty easy to get a good seal on a plastic face. Everyone else's face is going to be soft tissue. There's obviously some bony structure there, but getting that good seal is really, really important. And that's where having a 2-person BVM technique can be pretty helpful.
Brett, your second person can also watch for chest rise.
Yep, that's a great call out too, Doug. All right, allergic reactions. So we talked about some of the different types of shock last time. And so anaphylactic shock is going to be a distributive shock. So that's a pipe problem. If you remember, there were pump problems, pipe problems, volume problems. So this is a pipe problem. It's driven by the immune system having a hypersensitized reaction to some antigen. And so what that causes is kind of this sequela of things to happen physiologically. So on the, some of the skin signs that you're going to be getting, they get itchy skin, they're getting hives, they get swelling of the face from that angioedemia. It's very common that these patients kind of get this sense of dread almost. You get wheezing and problem breathing. And so one of the things that is causing that, especially the angioedema and the swelling, is that when they have an anaphylactic reaction, it is causing a vasodilation. So their blood vessels are widening, and you are getting kind of leaky blood vessels where that fluid is leaking into that surrounding tissue. In the respiratory system, it can trigger airway constrictions. So their airway is getting narrower, and that's primarily where you're hearing the wheezing and why they get that shortness of breath and difficulty breathing. And so what we will typically see in this patient is going to be the signs of shock that we see elsewhere. They're going to be hypotensive, their blood pressure is going to be low, they're going to be tachycardic, their heart rate is going to be high. And so this is a true medical emergency. We want to really be aware of this and doing everything we can to expedite this patient's care. Common in children and common by a number of different triggers. So you can have, it's very common for it to be peanuts and pine nuts. And then you can also have things like eggs and dairy that cause anaphylactic reactions. And then you can have environmental things, bee stings, and those types of things. So when we see a patient that has an anaphylactic reaction, a lot of times they're going to be known to have these reactions, and they will hopefully have an EpiPen with them. So OEC6, it talks about that you can either use or help a patient use an EpiPen. This is going to be largely dependent on your Hill policies and what your Hill allows you to do. And then the kind of easy phrase to remember this is that it is blue to the sky and orange to the thigh. So an EpiPen has a blue little safety cap. It won't allow it to deploy without that safety cap being removed. And then it has the orange side that has the needle. And it's important because it's a spring-loaded syringe. So when you press this down and the EpiPen deploys, it's going to start releasing that medication. You want to keep it pressed firmly against the skin for 10 seconds so that that entire syringe is able to deploy. Part of why epinephrine is used for anaphylactic shock is that epinephrine itself is a very strong vasoconstrictor. So if you remember, part of the problem that this patient has is that their blood vessels have dilated significantly. They're leaking into their interstitial tissues. That epinephrine is going to tighten up those blood vessels, help improve their blood pressure, and reverse that tension that they're having. So anytime that you're assisting a patient with an EpiPen, you want to make sure that the EpiPen is actually prescribed to that patient. That's an important safety check. Never put your thumb over that orange side because you will give yourself an epinephrine injection, which will not help the patient at all. You can do it through the skin, or sorry, you can through their clothing, but the ideal technique is that you're able to do it directly on the skin, and if you have it or have one in your patrol room, an alcohol wipe so that you can clean that skin first. You are able to do a second dose if they're still having symptoms after 10 minutes. Most of the epinephrine pens that are prescribed will have 2 EpiPens in the kit. So they usually have a second one for if they need to do an additional dose. So respiratory emergencies, you know, the vital signs that we're thinking about, respiratory rate and their pulse ox. And so it's really important, again, that we don't treat the numbers that we're treating the patient. We talked about before that elevation, you may have a little bit of hypoxia there. And the normal adult respiratory rate is going to be between 12 and 20. So when you have a patient that is outside of those ranges, that's when you really want to have those, again, the hairs on the back of your neck standing up. What's going on with their respiratory system right now? Children have a bit faster of a respiratory rate. So normal is 15 to 30. And again, when you have a pediatric patient that's outside that window, you really want to be thinking about, I need to be expediting their care because we're going to have pretty limited resources for dealing with a true respiratory emergency on the Hill. And so when we have patients that have respiratory distress or hypoxia, one of our tools that we have available to us is oxygen. So we can provide oxygen to these patients to help them with their respiratory distress. So for choking, this is going to be one of our respiratory emergencies. We're going to be doing on an adult and a child is abdominal thrusts, which are the Heimlich maneuver. And so we're going to be standing behind the individual. We're going to put our hand into a fist above their belly button. And the key is to go inward and upward until you have that obstruction dislodged. And then if that patient becomes unresponsive, we no longer are doing abdominal thrusts while they're on the ground. We move right into our CPR protocol. Just as a heads up, I don't know if anyone has renewed their CPR this year, but the AHA is going to be making changes to the adult and child choking algorithm as of their 2025 update. So for the sake of not confusing anyone, since most of us are still practicing under our current CPR standards, I'm gonna leave it with what the current practice is, but just be aware there's gonna be a change. For an infant, we're doing the 5 back slaps and the 5 chest thrusts. And one of the really important things here is that you keep that head tilted down because you want to be doing its work. So we have a patient that sustained a significant trauma. Our assessment showed that they had a femur injury, and we applied a traction splint. They've suddenly become short of breath with a stabbing pain on inhalation. What is the most likely cause? So we have A, shock, B, pulmonary embolism, C, anxiety, and D, hypoxia. Awesome. Great, everyone. So this is one of the things that can happen when you have a long bone injury, can happen with a femur fracture. And that is that you can get a pulmonary embolism. It's not from a blood clot, but it's actually from the fat globules. So in that bone marrow is fat. And if that fat enters into the blood, it can travel to the lungs. And that's how you can actually get a patient that develops a pulmonary embolism after a femur fracture. So pulmonary embolisms, what you will see outside of trauma is going to be a blood clot that travels to the lung. It's usually coming from the legs. And there's a couple risk factors to be aware of. One is if you've had a patient that has been traveling, like by airplane, where they've been sitting for a long time, over 4 hours, that can predispose them to developing a blood clot in the leg. If they've had any type of recent surgery, you can see this in pregnant patients, and you can also see it in women that are taking birth control pills. So the reason that it's important for us is that 30% of untreated patients with pulmonary embolism will die. It's a very serious respiratory emergency. Some of the signs and symptoms is going to be a sudden shortness of breath. They will also get pleuritic chest pain. So pleuritic chest pain is where you have a really sharp stabbing pain in the chest, and it gets worse when you take a deep breath. It gets worse when you cough. It's worse when you sneeze. And what's actually happening there is that you have irritation of that pleura, the lining around the lung, and that irritation makes it painful when they're breathing. People with pulmonary embolism will also frequently be coughing up some blood. They'll have blood-tinged sputum. The other two conditions that can develop into respiratory emergencies that we might see is congestive heart failure and COPD. What is the similarity between these two conditions is that when they are exacerbated, you will frequently have a patient that's presenting with fatigue and shortness of breath. So these can present as respiratory patients having a respiratory emergency. Congestive heart failure is actually a heart problem, and it occurs when the heart becomes too weak to pump blood effectively throughout the body. And so when that blood isn't getting pumped effectively, you start to have fluid that builds up in the pipes. The pipes get congested. So one of the things we talked about before, where you have some restriction around the heart, where the heart is not pumping effectively, a tension pneumothorax, or where you have cardiac tamponade, one of the physical signs that you'll see is jugular venous distension. That blood is pooling up in the venous system. You can have the same finding in congestive heart failure, where they get that jugular venous distension. If you carry a stethoscope, which I think you should, if you listen to their lungs, because they have some fluid that's around their lungs, there's a little bit of fluid that's actually down in the alveoli, in those air sacs. And so you will get a very distinctive rail sound, which is, it kind of sounds like when a kid is blowing bubbles into their milk, or almost the sound of when you're pulling Velcro apart. And that's a pretty classic lung sound for when someone has some fluid in their lungs. You'll also see in severe cases of congestive heart failure where they actually have some blood-tinged sputum. And so You want to be thinking in your mind of if that might be high altitude pulmonary edema. So there can be some overlap there. And then in COPD, this is going to be a respiratory condition where they have blockage in their airflow and their airway of their lungs. It's often from cigarette smoking, but one of the distinctive physical exam findings that you'll see is that these patients very typically get a barreled chest. So for most people, that side profile of their side profile of their chest is going to be narrow, and that front profile of their chest is going to be wide. In a COPD patient, their chest will get a barrel shape where that anterior, posterior, and transverse diameter start to get pretty similar. It's caused by two different conditions, emphysema, which is where you have damage in those little air sacs in the lung, and then chronic bronchitis, where you're getting those air tubes have a lot of irritation. So you'll, again, have a patient that's presenting with cough, fatigue, shortness of breath. They can get some wheezing here because, again, you are having that airway narrowing. And so it's also important to think that not everything that wheezes is asthma automatically. So you can have a patient in COPD that has wheezing, and it's because of that COPD is causing that wheezing. So these are two of the more common medical conditions, chronic medical conditions that are going to potentially turn into respiratory emergencies on the Hill if that patient is having an exacerbation. So history taking becomes really important here. We want our patient to kind of be our guide as if we have a patient that has congestive heart failure or COPD. And so we want to find out some history about the events leading up to the current episode. So have they been taking their medications? You'll frequently hear patients say that they take water pills if they have congestive heart failure. Those are diuretics, so it's helping reduce some of that fluid overload that they get. On an assessment, a patient that has congestive heart failure, if you look at their ankles, you may notice that their ankles are really swollen. Their socks are causing indentation in the skin. They can have something like pitting edema, where if you press on that skin stays sunken in. That's because they're so fluid overloaded. So these patients, when they're going to be having an exacerbation, that their CHF or their COPD is now worsened, they're going to usually be starting to do things like putting more pillows in their bed at night, so they're sleeping more upright. They're going to be waking up with shortness of breath. They may notice that they have some worsening swelling. So those are all kind of those historical clues that are going to give you some idea that this is a patient that's starting to have some worsening of this condition, and there is not going to be anything that we can do for them on the Hill but expedite them and get them off the Hill to higher level of care. The other thing that's helpful is if it's happened before, if it's ever been this bad before, how long have they been having that difficulty breathing for? And then you can have multiple things happen. So you can have a patient that has a history of COPD that develops a pulmonary embolism. So when people have sudden changes in their respiratory status, you also want to be thinking in the back of your mind, I need to move quickly because this is a patient that potentially has something else life-threatening. And then we always want to know if patients are getting tired, especially with respiratory conditions, because we need to be prepared if they have, respiratory arrest. I saw a question in the chat about high altitude pulmonary edema at our Southern California resorts. So it is most common over 8,000 feet. It would be pretty rare that we would see something at least in the Southern California resorts. I don't know the elevation at Mammoth. And it's not something that is typically going to present on their first day. So these patients that develop high altitude pulmonary edema almost always have been having preceding that symptoms of acute mountain sickness. And it usually is starting to show up on day 2 or through 4 of after they've gotten to elevation. So yeah, Mammoth at 11,000 feet, you could definitely have it happen. If people go up to elevation slowly, that helps prevent it. It's usually when they are kind of rapidly getting to a significant elevation. And then you're going to get, they're going to develop a dry, persistent cough. They're going to have respiratory symptoms that are worse at night. And then kind of that telltale sign that we look for is if they have pink frothy sputum. And remember, you can have patients that have congestive heart failure that also have pink frothy sputum. So you don't want that to be a red flag or a red herring. All right, we're going to talk about a couple pediatric considerations here. So asthma is one of the most common chronic diseases in children, and it's going to create that kind of classic presentation where they have shortness of breath and tight chest tightness. If your pediatric patient is not able to speak in full sentences, that's a red flag that you want to be thinking about. That usually is telling you that they're having a significant asthma attack. Wheezing is that hallmark sign for asthma. They'll usually be sitting in a tripod position, so they're upright, they're leaning forward. It's an easier way for them to breathe. And then one of the red flags that is important to know about is that you can have a silent asthmatic. So if you have a kid that has wheezing, you haven't done any treatment, they haven't taken a rescue inhaler, and now they're not wheezing any longer, what that can actually be a sign of is that their airway has gotten so tight that they're not actually moving air any longer, and that's why you've lost that wheezing sound. So that is a true respiratory emergency that we want to be addressing. So some of the important history that you'd want to get probably from one of their parents is, how many inhalers are they currently taking? I'm going to show you on a slide in a couple slides from now. There is this kind of stepwise approach of how they treat asthma that they'll add on more and more inhalers. So if you have a kid that's taking, 2 or 3 inhalers, that's typically a kid that has pretty significant asthma. If they're having to use their rescue inhaler every day, that's typically a kid that has some pretty significant asthma. You want to find out a little bit about what precipitated their current attack. Some of the common triggers for asthma is going to be exercise. So if they're skiing or snowboarding, that may be something that triggers that asthma attack, and also cold environments can trigger asthma attacks. And then how does it compare in severity to their past attacks? How long has this asthma attack been going on? And then anytime that we have altered mental status or they're starting to get drowsy and fatigued, those are also red flags that we really want to be thinking about. This is a patient that has some pending respiratory arrest, and we really need to be thinking about how are we going to expedite them off the hill, get them to higher level of care. So with OEC6, if your Hill policy allows it, you can assist the patient with using their inhaler. The inhalers that we want to use when someone's having an asthma attack is a rescue inhaler or albuterol inhaler. One of the side effects for you to be aware of is that this will certainly cause the patient to get tachycardic after they use their albuterol inhaler. So that's going to be a normal finding after they use their inhaler. There is a cap that's on the device. You'll take off that cap. It gets shaken. They want to breathe all the way out and then put the mouthpiece to their mouth, seal their lips around it. They want to inhale as deeply as they can while they're pressing down to release the medication. And then ideally, they're going to hold their breath for 5 to 10 seconds before they exhale. I found that kids that have asthma are typically pretty good at using their inhalers and know what to do. And so for most asthmatics, there's really not going to be a whole lot that you're having to assist them with. They're going to know how to use this medication. This is just to show you that there are a wide variety of inhalers that have been developed that they use to treat asthma. That top left grid is the rescue inhalers. Those are those ones that will be short acting and immediate to open up the airways. But what will often happen is if they're frequently having to use their rescue inhaler, if they're frequently having asthma attacks, their physicians or providers will add on more and more different inhalers to try to address some of that underlying inflammation that's triggering their asthma. Those other inhalers are not going to be helpful to them while they're having an asthma attack. The only thing that's going to be helpful to them during that asthma attack is using that albuterol rescue inhaler. The other thing for an airway emergency that will happen in pediatric patients is if they have an upper airway obstruction. So croup is one of the viral illnesses that causes upper airway obstruction, has a very distinctive barking cough. If any of you that had kids with croup, it's pretty noticeable. And again, you'll get that inspiratory stridor, so that high-pitched musical whistling sound when they're breathing in. They can also have upper airway obstruction from swallowing a foreign object. And you will frequently, when you have upper airway obstruction, they'll be having drooling where they are not able to control their secretions, and they will often be using accessory muscles to help them breathe. One of the things that's really important in a pediatric patient that has an upper airway obstruction is that you do not want to agitate them. You don't want them to get worked up. When they get worked up, they're going to have a hard time maintaining that respiratory drive.
Brett, the other thing is, if you agitate them, you may cause that, whatever's causing that obstruction to get lodged farther down in the airway, and it's very more difficult to retrieve.
Yep.
So you want to keep them very calm, very quiet, very settled.
Yep, exactly. Yep, and then Bentley had a great point in the chat too. For someone that's asthmatic, how many times have they already used their albuterol inhaler prior to us getting there? Because it gives us a good indication of where they're at. All right, another question here. Which of the following are differences between the pediatric airway and an adult airway? What are some of those considerations that we need to be thinking about? And sorry, the softer part is it should say softer soft tissue. Yes, exactly. So all of the above. So the challenge with airway for kids is that their head is big, their tongue is relatively bigger compared to an adult tongue, and the soft tissue in their neck is more compressible and isn't as developed. And so when you have them laying completely flat on a surface, the large side of their head will oftentimes cause their neck to be a little bit flexed, where their chin is kind of down at their chest. And that can compress the soft tissue of their airway passage. That large tongue is falling back to the back of the throat, causing that upper airway obstruction. And so oftentimes, just by doing a little bit of extension on that neck, you can bring that airway into a more ideal position. One of the other things, if you'll recall from when you're doing your CPR training and you are looking at, and you're doing the BVM on the pediatric mannequin, if you extend that neck too far, you can also kink off the airway that way. So it's not as dramatic of a head tilt chin lift as what you would find in an adult. You really just want to do a little bit of extension to find that kind of sweet spot. In an infant or in a small child, sometimes putting some padding behind their shoulder helps kind of overcome the fact that their head is so large and that the back of their head is so large in comparison to the rest of their positioning. This is a video on accessory muscle use. So luckily there's no sound, and then I will email out the video. There's a good video that I have of stridor that'll give you a good idea of that. So what you can see here is that this kid is really doing a tremendous amount of work of breathing. You can see all those muscles between their ribs tightening and really pulling to try to get them to get that airflow, moving air in and out. And then I'll send you the video with the stridor. Sorry that the sound didn't work. All right, wrapping up. So what is the helpful phrase to remember the proper technique for administering an EpiPen?
Blue sky, orange thigh.
Yep, exactly. Blue to the sky, orange to the thigh. And then if we're doing rescue breathing on someone, what is our rate? We're doing one breath every how many seconds?
6.
6 seconds, exactly. So we want to, I think, always assume that if you have someone that is short of breath, that they are big sick. This is a patient that we want to be expediting off the hill. Don't be afraid of giving them oxygen. We want to treat the patient. So if they are short of breath and they're having symptoms of respiratory distress, use one of those tools that we have in our tool belt. And then be wary of the pediatric respiratory patients, because these are patients that can crash pretty quick. So again, there's limited things that we're going to be able to do on the hill for these patients. They really need to get to that higher level of care. So we want to keep them calm, do the things that we can, and then get them to that higher level of care.
In an off-duty situation,
Yeah.
would boost oxygen help?
What is boost oxygen?
That it's an oxygen that it's over the counter that runners use sometimes, and hikers use it for to help them out with altitude sickness.
They sell it in the store
Get in sporting
at
goods stores.
Snow Valley.
Interesting.
95% oxygen, and it's aviator's oxygen.
Okay. I'm not super familiar with it. But yeah, I mean, if you have a patient, you know, in the pre-hospital environment, not on the hill, hopefully you have EMS pretty quick away. Most of us aren't going to be carrying an oxygen tank in our car. But, you know, I'd have to look a little bit more into exactly what the boost oxygen looks like. But it certainly is possible that if someone's hypoxic and having difficulty breathing, the problem will probably be if it's just a quick little, you know, one-time spurt of oxygen. I'm not sure how valuable that's going to be in a emergency situation. It'll probably be pretty limited.
It's a whole bottle.
I would suggest not using it if it's only 95%, because it will be very difficult to regulate how much they're actually getting. And you want 100% because you're going to be reporting how many liters per minute you gave. And the assumption when they get to a higher level of care is that you were using 100% at 1 liter per minute, 2 liters, whatever. So, and it may not be effective at only 95% instead of 100 for a medical thing.
All right. Could be a question at Snow Valley, since they sell it in the store, is have you had any extra oxygen today?
Yeah. Yep. That's a great point for some of that history. Or if you get there, I'm going to have to look into it, because if you get there and they're already on an oxygen device, you're going to need to kind of do some assessment there. So I will definitely look into it so I can be more familiar myself.
One more question on the airways.
Please.
If a person is wearing dentures or a bridge and they're in place, do you just leave it? Or if there's something loose, you can just go ahead and remove it?
Yeah, that is a very good question. I do not know off the top of my head what the OEC guidelines for a patient with denture are, so I don't want to misspeak. Do any of the OEC instructors know off the top of their head what OEC, if OEC has a guidance on that?
Is this causing an obstruction to their breathing, this device? That would be my guidance.
Yeah,
there's
so if it's
obstruction, remove
loose,
the obstruction.
yeah, if it's loose, then take it out. If it's secure in, then probably leave it in.
Well, if they're unresponsive, you always want to open the mouth and take a look and remove any debris or loose teeth or whatever that could become aspirated.
Yep, that's a great question. Let me look through the OEC text a little bit, and I'll include that in my my follow-up email. All right, and then we do have one more of these coming up next month. We're going to be talking about cardiovascular and neurologic emergencies, and then as always, please give me feedback on these talks so that we can improve them. If you take a picture with your phone, that'll be a QR code, and I'll send out in the email the link to the evaluation as well. Let me turn off the recording here, and then happy to